Amazing. Well, another mama came in. All of you that are here, all three of you, Angel, Crystal, and Lillian, are wanting kind of a similar experience, which is cool. So we can kind of tailor today our little workshop around focusing on helping you um, have an unmedicated birth and reduce risks for interventions with the use of your birth plan as an advocacy tool. So the birth plan, is not an illustration around how things will happen, right? It's just an advocacy tool. And it's a really great one when we use it that way. If we go into birth and we're like, can you please not cut the cord for a few minutes? Like, I prefer delayed cord clamping, something like that. What we're doing is we're like leaving a lot up to provider interpretation. If we say, I want delayed cord clamping, or I prefer this, your provider will cut the cord or clamp it whenever they think that delayed cord clamping is complete, whatever delayed cord clamping means to them. And that's okay if you're fine letting them decide that. But if you're really wanting to wait till the cord's done pulsing, for example, we just want to use language that is making sure that it's clear that that's what you want. And that's just one example. A lot of moms go in, like I'll read their birth plans. We're going to make your birth plan today. A lot of moms will send me their birth plan if they've already made it. And they're like, can you offer any insights? And I just change all the words around for them and see if they want to do it that way. To take it from like, I prefer no episiotomy. I would like to do intermittent monitoring if you think it's safe, or like leaving a lot up to provider interpretation. Obviously, if your provider thinks something isn't safe, they'll tell you that. But if we go in leaving so much up to interpretation and using language that's like, I prefer this, but whatever you think, we're not really utilizing the advocacy tool to the best of our ability. So since we're a group of mamas, and you probably will have different preferences, what I think might be best is if I just copy and paste the birth plan template into chat, and then all of you can copy and paste that into your notes and kind of fill it out as we go. Or I'll just go over it over this call. I'll record it and I can share it if you want to, like I can send it to you if you want to watch it later, or you could just kind of remember like what we talked about, and then you can go adjust it later whenever you're ready to make your birth plan in that template. Does that sound good?
Yeah, I'm fine with you copying and pasting, and then I can do it in my notes.
Okay, sounds perfect. So I'll just grab that really quick. I'm so excited to have three mamas here. My last birth plan building workshop was one mama. It varies. Sometimes I have five and sometimes I'll just have one, but it's fun when there's a few more moms. Okay, so let's find birth preference sheets. Here we go. And at the top, you will see that it says birth intention. If you're in my coaching program, you've done that like guided meditation to find your birth intention. It's really great. Okay, I'm pasting now. I think it's great to just like get clear on what it is that you really want in that like feeling, because then we can create a container that really supports like a peaceful experience, for example. Okay, why are you having technical issues? There we go. Okay, it is there. So I'm going to give it like 30 seconds and let you copy and paste this. And then after you do that, I'll go ahead and start going through it. And how we'll do this in the group is that I'll just like go over the first part and I'll kind of explain a little bit about it. Please unmute yourself or just like drop in the chat if you have any questions. Because if I say like, I accept artificial rupture of membranes, and I talk about it and then you're like, wait, what is that again? I want to like make sure you fully understand. And I don't want to go deep into anything that you like don't quite understand. So we have a whole hour so we can really go through each of these interventions and make sure that you kind of understand well what the risks and benefits are to it. So, okay, let's start with the beginning, which is I accept or decline the presence of students or additional staff. So every hospital is different, and some hospitals are teaching hospitals and they do have students. There are different kinds of students. Some students are there to just like observe and other ones are there to perform skills. And I just want to make it clear that it is not your responsibility to let anyone learn on you when you're giving birth. And I have seen like really not unethical ways of students learning on people who are giving birth, and ethical ways. And I'm a student, so I've, had to learn all these skills, but I didn't learn how to perform a cervical exam when the mom was in labor, where the provider had to like check behind me and make sure I was doing it right. We talked about that with our clients before and made sure that they felt like, yeah, I'm fine getting checked twice so the student can check like when I'm pregnant, not in labor. And then we got to the point where I was skilled at cervical checks and my preceptor trusted that I could perform them when someone was in labor correctly and didn't have to check behind me. But sometimes what will happen is like the student will be like, can I check you in labor? And they check you. And then provider or nurse or whoever is like, shepherding that student along will say, now I have to also check because like we want to make sure the student checked correctly. And like, you're not a guinea pig, you're giving birth. So we just want you to feel like so safe and secure. If you don't care if students are there, that's totally fine. You can take that out or just say, I accept. You can also say, I accept students in an observation role. If you want to say that, or you could just say decline. Another tip for like, if you're just wanting to limit the amount of people in your space when you're giving birth, some hospitals have a sign that you stick on the door, like at a hotel, that's like, do not disturb. I would ask if they have those. If they don't, order your own on Amazon or something and bring that and stick it on the door because it's amazing. Like as a birth doula, like I'm always surprised by how many people will walk in the hospital room. Mom is like naked, like giving birth and someone or in labor and the cafeteria woman will come in and be like, what would you like to order for lunch? And insurance will walk in and it's like, dude, like you shouldn't be coming in here right now. So putting a sign on the door is a good way to like reduce the amount of people coming in. And I do recommend you consider reducing people because people that you don't know kind of like walking in can make you feel really uncomfortable. And we really just want to protect you and feeling super safe, throughout your experience. So any questions? No. Okay, cool. Next is I accept or decline artificial rupture of membrane. So this is called AROM, or when we break the water, and that's when a provider will use either like it's like a condom, it looks like, that they put on the finger, and it has a little hook, or they have an actual, like a stick with a hook. It's called an amni hook. So either way, there's a little hook. They'll put it past your cervix, and then they'll kind of swipe on top of the baby's head where the amniotic sac is. There's 2 layers, so they want to swipe it sometimes twice to break both the layers. Sometimes it can cause a little scrape on baby's head, but typically that isn't an issue. The risks to breaking your water are that what can happen is the water in front of the baby's head can clear. And so there's like, right, all this water right in front of the baby's head, and we clear that water out of the way, and then the baby goes whoop, and they go like lower into the pelvis suddenly. And when they descend quickly, that can definitely increase the risk for a fetal heart tone drop because they'll have a vasovagal response. This is temporary. Typically, it's not an issue, but it's something to be aware of. If that ever happens, I saw this happen with a mama one time at a home birth. We called 911, flipped the mom in hands and knees, and by the time EMS arrived, the baby was perfectly fine. Hands and knees is a position that can resolve sometimes a heart tone drop because of maybe a cord compression or something like that. So that's a little tip. Also, this is so rare and really unlikely, but like, here's my amniotic sac. It fell out of my basket. If the cord, which you should find out in an anatomy ultrasound, but I did attend one birth one time where we had a surprise velamentous cord insertion. I don't know how we missed it. It might have been that the provider didn't see it on ultrasound. I don't know, like somehow it was missed, but usually the cord inserts in the center of the placenta. Sometimes it'll insert on the side of the placenta. So rarely. It could insert literally into the amniotic sac. It's crazy. So the cord right here is actually inserted into the amniotic sac, and then the vessels travel across the sac to the placenta. If we were to snag the cord or snag the amniotic sac where the vessels are and break a vessel, that could cause a fatal bleed, or it could be like an emergency. So unlikely that would happen. But in like full transparency around all the risks, of this, that is, potentially one. And it does open up the risk for infection. So as soon as the water bag is open, the risk for infection becomes present. If you're avoiding cervical exams, it's ideal to avoid them after 5. I mean, you can avoid them completely if you want, but 5, if your water bag is broken, is the absolute max we want to get. So just limiting them as much as possible is really important. If someone breaks it, the clock begins for how long you can stay pregnant before we're really worried about infection. If you don't have GBS, which is a bacteria they'll test you for at the end of pregnancy, research and evidence says you have 48 to 72 hours without increasing the risk of infection to baby. So you have quite a long time. If we're doing a lot of cervical exams, that time will go down. For sure. But just because that's what the evidence has to say, it doesn't mean that that's how everyone practices. There are some hospitals, like I have a friend who waited 24 hours after they broke her water trying to get her into labor. And then they came in at 24 hours and they're like, your water has been broken for 24 hours. Baby's not here. We need to do a C-section. And that's not true. She and her baby were fine. They could have advocated to wait longer and try for a vaginal birth. But sometimes you might start getting some pressure for either induction or even C-section if the water has been broken for a certain period of time. So that clock sort of element is something to be aware of as a risk. The only benefit to breaking your water is seen on observational studies, not in randomized control trials. So it's not an evidence-based benefit. And so it means it's not evidence-based that it can speed up your labor. That's the benefit. But it has been seen on a case-by-case basis to maybe make your labor faster, but we don't have any good research that shows that's actually true. I have seen a lot of providers say, like, do you want your baby to come? This happened to my student recently. Do you want your baby to come today? And my student was like, yeah. And the provider was like, well, then I'm going to break your water. My student was like, hold up. you know, that is something that can happen. Providers think like if we're messing with things and we're like speeding it along. But that's just not true. It's not evidence-based. Breaking your water is not going to make your labor faster. It could, but it also could not. I have seen like if you're pushing, and the baby is just like right there, but there's a lot of water in front of their head. Like the bag can be born around the baby. And so it doesn't have to break for the baby to come out. But sometimes like if the bag is really thick, there's a lot of water in front of the baby's head and they're just not doing that like final rotation. Like they need to just do that little rotation to be able to come out and they're just not quite there yet. And we break the water and then the baby just rotates and comes out. And, that has happened before. And I think that's why in observational studies, we have found that pushing can be a little shorter if you break the bag. Anyway, so why I'm giving you this whole speech is that it's important to be aware some providers might come in and be like trying to speed up your labor. That's not evidence-based, or they might just routinely break your water. Breaking your water just comes with risks and there aren't benefits really to it, except for potentially speeding up your labor. Yeah, Crystal, what's your question?
I was just gonna add to that, or I guess ask. So and I think you might have just answered it, but I guess there is no medical necessity to artificially rupture your membranes then.
No, there's no medical need to artificially rupture your membranes. The water bag breaks most of the time, and 1 in 85,000 babies will be born with the amniotic sac intact, which is very interesting. So it's very rare, but yeah, it's not needed medically at all.
Okay, perfect. And then just so that for my personal brain, you said it can take, once the membranes are ruptured, it's 20, you said 48 to 72 hours before they start worrying about infection, right?
But they will start worrying about infection in 24
Oh,
hours.
24. Okay.
But the research and evidence from evidence-based birth says that actually it's 48 to 72. The 24-hour rule comes from the 1950s when providers weren't washing their hands in between caring for people in labor. And so they were spreading infections to babies. So if your water had been broken for 24 hours, your baby was likely to get an infection. But that's from the 1950s. It's not from today,
Oh,
when we use sterile gloves and wash our hands and things like that. So
okay,
um,
perfect.
yeah, if you do have GBS, the research and evidence says we want you to be going into labor. So it doesn't mean you have to have your baby, but you want to be getting contractions by 18 hours. So that one's a little bit tighter. So, okay, that's a ROM. So the next one is I accept or decline routine cervical exams. I'm going to sneeze. No, I'm not. Okay. Any questions about routine cervical exams versus like case by case? No. Okay, cool. Yeah. So maybe I'll just say like on a case by case basis. Actually, I'll say this. Get a cervical exam if it will give you meaningful information to change the course of action. Labor's stalling out. Like the contraction patterns aren't consistent anymore. What should we do? oh, like let's do a cervical exam and like see what's going on. Oh my gosh, baby is not well applied to the cervix. Baby, because we can feel the sutures on top of baby's head, which is a diamond and a triangle. Baby is like kind of like this on the cervix. They're really favoring one side and leaning that way, and they're not putting good pressure on the cervix. So the cervix isn't being stimulated well enough to release oxytocin and to give you that continuous, consistent labor pattern. And so what we need to do, since baby's facing this way, is we need to do some spinning babies. Baby's really on the left. Let's do some spinning babies and let's like really favor the right. Let's open up the right leg. Let's lie on our left side with our right, or lie on our right side, right? To like try to get the baby to the right side. That gives us meaningful information to change the course of action and maybe fix a positioning problem. And if you're in my coaching program, you'll be learning what to do in that kind of situation. So we want the baby to be well applied. So that's really helpful to know. Also, like, are you wanting to use an induction tool? If maybe you're in early labor for a while and you're like, why is it not like kicking into gear? Like, why am I not going into active labor yet? And like someone can check you maybe and like kind of see what's going on. If they know your cervix is open a little bit, you could do a membrane sweep if you want to just try to like kick things into gear if you want, you know. So it's like helpful to give you information, but there's no research and evidence that shows that routine cervical exams, meaning you get an exam every 3 to 4 hours just to assess your progress, improves outcomes for mothers and babies. They do not. The risks to cervical exams is that if your membranes are open, it can increase the risk for infection. It can be uncomfortable. They can be unwanted, and a lot of moms don't know that they can decline them. So you can totally get it if you're curious, you know. If you, let's see at this language, you can just say, I decline routine cervical exams if you don't want them or accept them. You can also say like, I'm open to cervical exams if needed, or like, I'll request one if I want one. I also recommend in here that you consider putting in language around like, what would it be? Like if I hear, or maybe if I get an exam, don't tell me the number. And like, please use encouraging language. I think that's a good thing to put there if you think that the number will freak you out. If you don't think the number will freak you out, then like, you know, whatever, go for it. But some, like, there's a mom I supported with her first, she just had her second birth and had an amazing birth. With her first, they checked her and she was 4 and she was really tired and was just so defeated. And she was like, I can't do this if I'm 4. You can go from 4 to baby in 5 minutes. There's that video that went viral on Instagram a while ago of a woman who went in and they checked her and they said, you're 3 centimeters, so we can't admit you, you're not really in labor yet. And then she had her baby in the car 8 minutes later. So cervical exams are not a timeline guide. You know, but it can feel defeating to hear that you're 3 centimeters, even though you could have a baby in 8 minutes. We just don't know, but you might be like so sad that you're not farther along. So if someone just checks you and they're like, you're doing great, your cervix is making lots of great changes, you know, and like that's all, then sometimes that can feel really helpful just to have that and not hear the number. So anyway, that's something you can add. Questions about that? Okay, amazing. Next would be, I will wear my own clothes. That's up to you. You can wear a hospital gown if you want to. There's also like birth gowns. There's labor skirts. I got a labor skirt, ended up just being naked anyway, but I thought that I would try because it's kind of nice to just have your like booty covered, you know, on your hands and knees all the time. I ended up just like whatever. I got like covered in amniotic fluid or something, but just like a little skirt that, you know, covers your booty. You can do that if you want. Photo and video will be taken. So remove that or keep that if you want. You have the right to take photo and video of your birth. Some providers don't like that. And a good compromise would be like, okay, we won't record you, provider, but we'll still record mom, or we'll record from this angle. So we're not watching provider hands and getting that on video because they're worried about liability and they don't want that sometimes. So that's like a good compromise. You do have the right to do that. If someone is like, no, you can't take any photo or video of your birth, like you can say, I know that I can and I will. And that's okay too. But finding a way that makes everyone feel comfortable is important as well, because we don't want like your care team to feel uncomfortable. So sometimes you can just say like, I understand it's really important to us that we get a video. So we're just going to record mom and we won't record you, you know. Okay. What's next? Next is monitoring. So I accept or decline continuous monitoring, even if it's wireless, and then I accept or decline intermittent monitoring. So wireless monitoring, a lot of moms I'll be like, are you doing intermittent or wireless? And they're like, or intermittent or continuous. And they're like, I'm doing wireless. And they think that like wireless is kind of like intermittent, like it's better. It is better to do wireless if you're going to do continuous, because with continuous monitoring, they have the straps around your belly. One measures your contractions and the other measures baby's heart rate, and that's connected by wires to a machine. So you can get out of bed, but you can't really go very far with those monitors. Wireless is great because then you can like move around and go all around the hospital and go on a walk or whatever, and you're being monitored. So that's amazing. If you're doing continuous, definitely advocate for wireless. Some places say like we have wireless, but they only have it for a few rooms or something like that. So it's just good to like be clear about that. So the difference between intermittent monitoring and continuous monitoring is that in intermittent monitoring, we found that that is a safe way to monitor baby throughout labor without impacting outcomes, and it decreases your cesarean risk. So continuous monitoring monitors you all throughout labor. Intermittent monitoring is when someone goes in with a Doppler, where they are listening to your baby's heart rate now, like at prenatal appointments, and they'll listen with a Doppler every 30 minutes. It's like 10 to 30 minutes, somewhere in there, and it kind of depends on what stage of labor you're in, but for most of labor, typically it's every 30 minutes. The baby's heart rate has normal variability, so all throughout labor, between 110 and 160, your baby's heart rate will fluctuate, but it'll stay mostly around their baseline. And your baby's baseline could be 120, it could be 150, just like where your baby tends to hang out. After a contraction is when we'll see if a baby is tolerating labor well. So typically with intermittent monitoring, when it's done properly, they'll listen to you and your baby at the end of a contraction, and they'll wait to see what the baby's heart rate does. And if the baby's heart rate goes a little below baseline, but then it recovers quickly back to that baby's baseline, we know that baby's well oxygenated and they're doing well. If the baby starts to slowly like come back to baseline, but it take a little while, or they get like much lower than they typically do, or if it even goes below normal, then we know that like something's not okay. With intermittent monitoring, it's safe to do for low risk parents outside of the hospital. This is how midwives monitor for home births and birth center births, because babies tell us that they're not okay before they're really not okay. They give us some warning. And sometimes that warning just signals to us that baby's not really comfortable. There's a cord compression, or they're not happy in that position, and we get mom at hands and knees, and then that resolves sometimes. Or other times it means that baby's getting stressed out and we need to consider getting baby born faster somehow. Yeah, so I will say, like, if you do continuous monitoring, that, just to summarize the research, that increases your risk for a C-section without improving outcomes for babies. There is this one little piece of it that I'll share, which is that we looked at the 2017 Cochrane review. There are no differences in infection and NICU admission and APGAR scores, like all the things to assess if babies like are doing well. The only thing that was different is that in the intermittent group, the babies had a really, really like low but slight increase in newborn seizure rates. I think it was 0.15 in continuous and like zero point 0.3 or something like that in the intermittent. And so that's like the only thing to be aware of. But what evidence-based birth says is that, first off, we don't have any research on the long-term implications of a newborn seizure. So we don't know how important it is to prevent them. The second thing that they said was, if you would have to continuously monitor 667 people, and out of those people, I think it's 69 of them would have a unnecessary cesarean. 69 people would have an unnecessary cesarean to prevent one newborn seizure. I think it's 69 or it's 67 or something, one of those numbers. I should like fact check it, but it's 69, 67 anyway. Yeah, so that kind of like hopefully can help clarify that a little bit. Does anyone have questions about the difference between intermittent and continuous monitoring? No? Okay, amazing. Let's see. I wanted to say one more thing about it. There's one more piece, maybe not piece, option, one more option to continuous monitoring, which is internal. And internal, they would have to break your water. So it does come with an increased risk for infection, because we're breaking the water and then we're like putting things inside your body. But otherwise, there aren't many other risks associated with it. It just comes with the same ones as continuous monitoring, where they take like a little, I think it's a copper coil, and they put it into the baby's scalp. They kind of spiral it in. It just goes into the scalp. That can cause some like bruising, swelling, things like that on baby's head. And that's listening to baby's heart rate. Then they put an intrauterine pressure catheter, an IUPC, inside your uterus. And that measures the strength of your contractions. The only benefit is, I would say, quote, benefit to internal monitoring is that you can identify the strength of your contractions. External monitoring, you can't. But when do we actually need to know the strength of your contractions? Like, when is that actually necessary, and when is getting that information worth the risk of infection? I don't know. I can't name anything yet, but I have a whole career ahead of me, and maybe one day I'll discover the answer to that. But so far, I haven't found any. So just want you to be aware of that. Okay, any questions? No? Okay, good. Let's see. Okay, after that is IV access. So I accept or decline the IV/HEP block. So you can say, I accept an IV and HEP block. You could say, I decline the IV, I accept the HEP block. The HEP block is the IV port access that they put into your wrist typically, or your hand, not your wrist. They put it in your hand. The IV is when they actually will put fluids into your body. So you can accept the HEP block and decline the IV if you want. You can also decline both if you want to. If you're a person who you're just like, I hate needles. I'm so scared of like getting the IV when I get to the hospital. You know what I mean? Like, it's okay if you don't want it. The reason why they want you to have it is because if something were to happen, they have IV access, which makes sense. I will say though, that as a person who's well versed in out of hospital birth, as a student midwife, we don't put IVs in people routinely when they are having a normal physiologic birth, because unless like they have a high risk for hemorrhage, and you can ask your provider if you're a high risk for hemorrhage, if you have low platelets, if there's like a reason to be concerned that you might hemorrhage, maybe having an IV access would be good. If you do hemorrhage and you don't have IV access, they could give you a shot of Pitocin. They could give you misoprostol tablets in your mouth, and those work. The shot works immediately. The miso takes a second to work, but it works longer, and the shot wears away faster. So those combined is typically like gives you a good amount of protection while they get the IV in, and the IV will give you just continuous Pitocin. I've assisted many hemorrhages where we didn't need to put the IV in because just those medications were all that was needed. Yeah, so not providing medical advice, just like offering an invitation to kind of explore those options and make a choice that really feels best to you. For some people, yes, like getting a HEP block is really the right choice for them and really important. And a lot of people having an unmedicated birth won't need it at all. Having an IV in labor for hydration specifically, it's been shown in research that eating and drinking is better than using an IV for hydration. And if you get dehydrated, an IV is a really, really excellent tool that you can use. Anyway, so that's kind of some information about that. Any questions about the IV or the HEP block? No? Okay, amazing. And then I will eat and drink as I feel is needed during labor. So I recommend that you have a little cooler, and in your fridge at the end of your pregnancy, when you think you're going to go into labor soon, just always keep like grapes in your fridge, just like some grapes or berries, some produce you can throw in the cooler, and bring cheese sticks and some pre-made protein shakes, or maybe a little thing of hemp or whatever you use. Hemp milk is what we use, or oat milk, and the blender bottle, and your like powder for a protein shake. Just like have some of that stuff. We want to have protein, and we want to support you with blood sugar too. If you have low blood sugar in labor, your baby will get low blood sugar, and babies being born with low blood sugar is actually really, really dangerous. It's something that can be resolved with supplementation, but we just want to avoid that. And we can protect your baby from that by you supporting your blood sugar. Don't eat candy in labor. The only infection I've ever seen was when we broke her, well, I didn't, but the provider broke her water and was like, we're going to have a baby and break her water. And she was in labor for 9 more hours before we finally transferred her. So that wasn't clearly like the thing that got the baby out. And she didn't develop an infection. And she got a lot of cervical exams, and she was eating Sour Patch Kids, like a whole bag of Sour Patch Kids, and was just eating it. And I did a little research later, and I read a little bit about like how high levels of sugar in the blood can help bacteria grow, basically. So we don't want to like eat a bunch of candy, but We do want to keep our sugar up. If you start feeling exhausted or weak, taking a little spoonful of honey, bring a little thing of honey or a honey stick. Having a little juice, like something to just give you a little blood sugar boost, can be really helpful. And then, yeah, focus on protein and hydration. Those are the three things. You can bring like electrolytes or coconut water. Hospital food typically isn't very good. So you want to bring your own protein and fruit and whole like good foods that make you feel good. So okay, the next one is going to be labor coping. So it sounds like all of you are wanting an unmedicated birth. So I would say I plan for an unmedicated birth. Do not suggest pain medications. This is so important because a lot of the time we get to a place where we're like, I can't do this anymore. And you feel like I need something else to help me. And if other people are just waiting to give you the epidural, and they're like, as soon as she says she's ready, we're going to give it to her, and maybe later you look back and you're like, that's not really actually what I wanted. I just needed more support. So if you are like, I'm open to the epidural, you don't think you have to put this here, but if you really don't want one, please say don't suggest pain medications and make that really clear. We don't want that to be suggested. You can say, I'll ask for it if I want it. But to take it even a step further, if you're like, I really, really, really don't want an epidural, what you could do with your support team is to tell them, if I say I want an epidural, it doesn't mean I want an epidural the first time I say it. It just means that I need more support. It's good to go into birth acknowledging the reality that you'll probably face your own self-doubt. And that's what we do through birth. We face our own self-doubt because we go through something that we haven't gone through before, or we go through a new experience. Like every birth is new. If you've had a baby before, this is a new experience. And each time, like I've had 3 babies, each time you prove to yourself that you can do something you didn't think you can do. But when we do a thing we don't think we can do, we face our own self-doubt as we learn that we actually can do it. And I just posted in my podcast, it's called the Peaceful Birth Podcast, a story of one of my mamas. And the whole labor, she was like, she had a Pitocin labor, by the way. She didn't get an epidural, but she did get Pitocin, and Pitocin can make your contractions more painful. And she did it. And she was like, I want the epidural. I need the epidural. She would just like say that, but everyone knew she actually didn't want that. She just had to express her own self-doubt. And everyone knew that if she was saying that, it just means that we need to give her more emotional support. And of course, if she got to a place where she was like, no, you guys, I'm being serious. I'm really suffering. I like need the epidural. Like that's different. But that's not what she needed. She just had to express her self-doubt. So creating a container where you can do that, I think can be really helpful. So you could even say something like, if I say I want an epidural, first try more support if you want. And then you could also say like, I'm open to IV opioids, or I'm open to nitrous, and just say will request when I'm ready. The next is I will use low light, movement, water, and comfort tools. I just popped a little thing in there. I think some moms will write a whole list about all their like the things they're going to do. I don't think you need that because your provider doesn't really need to know the whole list of all the things you're gonna do. Instead, I just kind of like threw in a quick little like, I'm planning to use different comfort tools. I want the lights low. I want to use water. I'm going to move my body, which is like pretty standard. And then, if you feel like you want to list like for your partner, I have like partner support flashcards. Text me for those and I'll send them to you. Or I think that maybe I was just listening to a testimonial video from a mom in my program, and she was like, I thought I needed a list of all those things. But then like by the time I got to the end of my pregnancy and I was ready to go into labor, I like had integrated all that, and I didn't feel like I needed that list because I had learned it with you. So usually moms are like not actually needing a list for themselves. Okay. Stop me if you have any questions. Next is pushing and delivery. This is really important. These are yes, that I highly recommend everyone has in their birth preference sheet around pushing. And so the first is, I will push instinctively. Do not coach me to push. This is really, really important. So if you are feeling like I want to have a kind of birth experience where I'm listening to my body, if you get the fetal ejection reflex, I'm allowing that to take over and pushing spontaneously. You want to write something like that in here, because typically in a hospital setting, they'll just go to like, okay, time to push, hold your breath and like count to 10. Some providers are like, we're all coming in, get on your back. We're going to hold your legs back and start coaching you to push. Other providers will come in and they'll be a lot more like compassionate and slow and kind of check in with you. And they'll be like, okay, it sounds like you're pushing. I want you to start doing this. Time to hold your breath and push. So even though they're kind of meeting you where you're at in whatever position you are, you're still being coached. And it's okay to be coached if you want to be coached. But there are two different ways to address pushing. One is through coaching, and the other one is through just sitting back and trusting and letting you do the work. And sometimes we can kind of meet in the middle if you feel like you need a little support here and there. There's no wrong path. It's just about choosing what feels best for you. If you're wanting that kind of pushing experience, you just have to make that clear because that goes against probably what the routine in the hospital is. Like I said, every provider in hospital is different, but it's pretty common for them to just go straight to directed. Directed pushing, especially if you're on your back with your legs pulled all the way back, increases your risk for tearing. And the reason why is because there's only so much like flexibility, like your pelvic floor muscles can only access so much, right? Like pulling. And if your legs are being pulled back, it's pulling on this whole posterior, the back chain of muscles from your legs all the way to your pelvic floor. And if we're pulling that back, we're already increasing the tension that's there. And then when baby comes out, we increase the tension even more. And your pelvic floor and your perineum really can only access so much tension until it tears. So to reduce that risk, we want you to be in whatever position you want to be in that feels comfortable, that helps you to slow down that process. We want to avoid pulling your legs back as far as possible. If you want to be on your back, a mom who's giving birth spontaneously without coaching, who ends up on her back, will kind of go to her back with her legs like open, but she's not going to reach down, grab both her legs and pull them back to her head. That's like not something you see. And I've seen a lot of births where moms just like feel comfortable on their back, but their legs are just kind of like up like this. They're not like pulling them way back. And that's not necessary. If the baby's shoulders get stuck and they want to like get you back on your back with your legs all the way up, it's called McRoberts. That's one position that can sometimes help the shoulder come out. Another position will be to put you on hands and knees. That's called the Gaskin maneuver. Either way, like that's kind of the only reason why we need you to be all the way on your back. Or if you actually needed forceps or vacuum, which are those tools to guide the baby out. Or if even more rare, you actually needed an episiotomy. But the evidence-based episiotomy rate is 1%. So that means that like your risk of needing an episiotomy is just slim to none. And we want to do everything we can to avoid episiotomy. It's where they take sterile scissors and will make an incision through some of the perineum. We want to avoid that. So that leads me to the next point, which is I decline episiotomy. Please don't say I prefer no episiotomy. Everyone knows you prefer to not have an episiotomy. Nobody wants that. Go in declining it. Because it's such a dangerous procedure to perform on your body and should only happen when there are no other options and we're in a true emergency where baby's like life depends on doing an episiotomy to get them out. That is the only reason why we should ever do an episiotomy. So a provider who practices episiotomy in an evidence-based way, if you ask them, what's your episiotomy rate? They might say, in my whole 20-year career, I've done them less than a handful of times. I can count on one hand how many times I perform them. Or maybe they'll go their whole career and like not even do one. My midwife preceptor went 20 years before she did her first, and I wasn't there for that, but I was working with her at the time and she told me about the first time she had to do it. So that's an evidence-based episiotomy rate. If your provider has an episiotomy rate that's above 1%, you can look up your hospital's episiotomy rate too. Then we want to do even more to reduce your risk, which means like we don't want you to birth on your back. We want to choose, I don't want to tell you what to do, but maybe I'll say an evidence-based way to avoid episiotomy is to birth upright. So you're in hands and knees, you're standing, you're kneeling, squatting, something like that. We are choosing provider hands off. So your provider's not touching your baby or your body when your baby comes out. And I don't know if it's evidence-based or not, but I believe if you put I decline episiotomy, that helps to have that. And then we want to have a doula or a partner or someone there who can chime in if they see a provider picking up scissors and say, what are you doing? I see you're picking up scissors, you know what I mean? And to also like kind of protect you and communicate with providers about what your preferences are. So the next is I will push and give birth in whatever position I choose. I see a lot of moms say like, I I prefer freedom of movement. I want to give birth in whatever position can I, you know what I mean? You don't have to ask permission. You have the human right to birth in whatever position you want. So outside of those rare actual, like the rare situations where for a medical reason we need to be on our back, right? Which is where we actually need an episiotomy. So that would mean like baby's heart rate drops so far and we can't get baby, we need to get baby out immediately. Or you need forceps or vacuum, or the head comes out, but then the shoulders get stuck. In which case you don't actually have to be on your back. You could do hands and knees, but some providers prefer you on your back. I can't think of any other reason. Um, those are the only other reasons to for pushing, like to be on your back. Otherwise, unless being on your back feels good for you, there's no benefit. It's actually increasing your risk for a C-section to be birthing on your back because your baby compresses on a blood vessel that runs behind your uterus. So simply being in hands and knees or upright, like standing, sitting on the toilet, like something like that, those positions are not putting that pressure on the blood vessel. If you feel tired and you want to lie down, you could lie on your side and push that way. But birthing on your back only benefits, I would say benefits the provider. Honestly, I don't see how it is more convenient for the provider to like push or support a mom when they have like an increased risk for tearing and then the provider has to do way more work, or an increased risk for heart tones coming down, in which case the provider has a more scary delivery. As a student midwife, I've only caught like 10 babies, so not very many, but still like it's easy to you just lean over, you just get on your knees, like wherever the mom is, you just do that. And moms being on their back routinely doesn't benefit me like when I was in that role, because if they tore, then I would have like way more work to do. So anyway, I don't understand, but just wanted to share that. You can birth in whatever position you want. The last one is do not touch my genitals without my verbal consent. This one is really important. If you are someone who has experienced trauma before, if you feel like people touching me is something that I'm kind of worried about, or cervical exams or something I want to avoid, if you don't care, then you can take that part out. For some reason in birth, people think it's okay to just like anyone could just put their fingers in your vagina. That's like not true. You know, it's like not okay for anyone to perform any kind of procedure. Or intervention on your body without your informed consent, meaning you understand the risks and benefits. You understand that you can say no and you're choosing to say yes. That's what informed consent is. So we want that to be intact. Any questions about pushing and delivery? Cool. Okay. I will also say if you're choosing provider hands off, I should probably put that in this template too, now that I'm thinking about it. If you want your provider to not touch your baby in your body when your baby comes out, which is an evidence-based way to reduce your risk for episiotomy and tearing, you probably want to say, I choose provider hands off. Do not touch my body or my baby during delivery. And provider hands off doesn't mean they're off in the corner. It means that they're standing there. And if there is an issue, then they'll step in. But if there's not an issue, then the baby could just come out into your partner's hands, into your hands. If you're just on the bed, like they can come out right onto the bed. Someone needs to catch the baby in hands and knees or standing, you know, but it's a lot harder to like perform an episiotomy or something like that when you're in those positions. And also providers can catch just with open hands. So you can say, I want an open hand delivery, but I don't want you to do the maneuvers to pull on baby. And I can't go too deep into that because I don't have time to today in this workshop, but just know that you have some options. If you communicate that to your provider and your provider's really unsupportive, like sometimes you can trust that a provider can do a warm compress and then remove the warm compress and like let the baby guide to their hands. But other people, like you just don't want your provider to access your genitals at all, in which case, if you can't trust them, it might be better if you really do choose hands off and not let them anywhere near. If there's someone who has a really high episiotomy rate, if there's someone who has expressed to you that they won't like respect your choice to be more hands off when the baby's head's coming out, things like that. So it's like good to kind of make a personal plan. And that's what I can support you with in my coaching program to kind of help navigate depending on who your provider is. So, okay, next is immediate postpartum. So do not clamp the cord until I give you verbal consent. That's if you are like wanting delayed cord clamping, but you want it to be longer than how they define it. So typically it's defined 90 seconds to 2 minutes, somewhere in there. If you're fine with that, then that's great. If you want the cord to stay intact longer, then maybe put something like this down so you could just be the one in charge of like when to clamp the cord. The cord is still pulsing for 5 minutes, 10 minutes, 15 minutes. It's wild. It can take a little while sometimes. So usually it's only like a few minutes. And when it's pulsing, the baby's still getting blood. So if you want your baby to get all the blood they can get, waiting until it's done pulsing is an option. Um, I put in here my partner will cut the cord. That's pretty common. So I just thought I would say that. You can make that however you want. There's also like cord burning you can do, which is a whole nother thing that's kind of cool. I have a class called the Healthy Start Plan that's free in the classroom tab, and it goes over a lot of postpartum stuff and immediate postpartum, and it talks about that. Next is Pitocin in the third stage of labor. So after baby comes out and the placenta is still inside, that is called the third stage of labor. So that means that we still need to deliver the placenta basically. You could say either I decline Pitocin in the third stage of labor unless I show signs of hemorrhage. Or you can say I consent to Pitocin in the third stage. So choose what feels best for you. For my first two, I chose not to do Pitocin. This is active management, which means that we just routinely do the thing. I chose expectant management, and that's how out of hospital births typically are. Every midwife is so different, though. But my midwife was more just routinely kind of did expectant, meaning like I'll watch for signs of heavy bleeding. If I see that, then I will treat it. And with my second, I had a really fast birth, and then I didn't hemorrhage, but I lost quite a bit of blood, and I felt kind of weak and nauseous because I was a little anemic and I didn't tolerate that very well. And it made recovery a little harder because I just felt more weak for a little while. So with my third, I was like, give me the Pitocin. I want the Pitocin. And they gave me Pitocin immediately after a baby was born, and that was great. So you can also check in with them about how much they give you, because midwives in my community, like they'll just give you a shot with just a really little bit. Is it a unit? I don't want to say it wrong, but I feel like it's like 1 unit or 2 units. And I might not be unit. I can't quite remember. It was a while ago, and I had two babies since my student midwifery training. So, but in the hospital, they might give you quite a lot more, and you might not need all that. So you can ask them like how much they give for routine active management, and just like maybe look into that a little bit more and do your own research around it if you feel like you don't want that much. Pitocin, if you get it throughout labor, get a lot of it, it can cause swelling, which can flatten your nipples and make nursing harder. Typically, like there really aren't a lot of risks, to my knowledge, like of getting Pitocin after your baby is born. If you get a lot of Pitocin, it can cause the swelling, but the other big risks aren't present because you're not like the risks to baby, because baby's out now. I will say there was a study that came out that said getting Pitocin will impact your hormones and increase the risk for postpartum depression. And Evidence-Based Birth viewed that study and said it was such poor quality. They were shocked it made it past peer review. So that's not an evidence-based thing. That's a myth in my mind. Yeah. Okay, and then the next one would be do not touch or rub my baby with blankets unless they need resuscitation. So after babies are born, it's very routine in hospitals to like put the baby on mom's chest. And, I would also maybe pop skin to skin in here. Most hospitals do skin to skin routinely, but some hospitals will just put the baby on your hospital gown, or like, or I see nurses, they throw a blanket on the mom's chest. I'm like, why are you doing that? To put the baby on the blanket, put the baby on the mom. Anyway, so we want skin to skin. And then there's two nurses or even three sometimes rubbing the baby. Someone's rubbing the baby's head, someone's rubbing their back, someone's like flicking their toes. And that's necessary if the baby needs resuscitation. If the baby comes out and they're flappy, it's like that. They're like floppy. They're a little gray or purpley. Their chest, like their hands and feet will be purpley no matter what, but their chest should be pink. If it's not, and they're flappy and they're not showing any respiratory effort, they're not like, like trying to cry, then that baby does need some support. If your baby comes out and their chest and their face and, belly is pink and they are crying, they're like, they like cough and start crying immediately. Why do we need to rub that baby? We don't. Or suction that baby. NRP, I recertified a year ago or something, a year and a half ago, and when I did, they told me that they changed, like they updated their guidelines in this new version because with that suction bulb, right? They were putting the suction bulb in every baby's mouth and suctioning fluid out of their mouth. When the baby's head comes out, they're squeezed. And when the baby's head is squeezed, it like releases some of that fluid. So that's like a normal process of to birth is to clear that fluid from the baby's mouth. Suctioning they found routinely was causing damage to the back of babies' throats. So now it's suction if needed, and that's newly updated. So not every provider knows that, to my understanding, because they haven't maybe recertified every nurse. And also, it just takes time for new evidence to make its way into practice. And so some people just are used to that, and it might just take a while for them to stop. So it is damaging to routinely suction every baby. I don't think there's any research on negative effects from rubbing babies to my excuse me, to my knowledge. But I just like can't imagine having my baby and all these people are around me and like, yeah, you did it, a baby, wow. And they're like rubbing the, it's like, oh my God. And the poor little baby is like this brand new little baby and it's just being like aggressively rubbed with towels. You know, if your baby is like crying and they're pink and they're doing well, they don't need suction. And they don't need resuscitation, which means they don't need the rubbing. The rubbing's the first step of resuscitation. So sometimes babies can cry, but they do actually later we find out like they're crying, but they maybe have a little bit more fluid that they need to clear, or they start to clear more fluid, and then we do need suction because there's somewhere in their lungs they cry and work out, and then it gets to their mouth. And you know, so I'm not saying if they come out crying they never need suction, but we only need to suction a baby if we're following NRP, if the baby needs suction. So, okay, the next would be cesarean. So, I will say if you're having a cesarean, it's you have the right to skin with your baby. You know, you have that right, and it is sometimes hard in a space where providers are doing things the way that they're used to advocate for immediate skin to skin and to actually get it, because that's not what they do. And some hospitals do immediate skin to skin after C-section, and some providers don't. The research shows that, especially for preterm and sick babies, skin to skin improves their, it reduces infant mortality. So you can say that denying skin to skin for a baby after they're born by cesarean specifically increases their risk of death. It's really, really interesting and mind blowing. And many hospitals are doing routine skin to skin, but some of them aren't. So I just recommend that you, if you really want your baby to be skin to skin, that you put some of these things in here. I request delayed cord clamping, baby will be brought to me skin to skin. You could the vaginal swab for baby's microbiome. I don't think that's well researched, but something I thought I'd pop on here for people who are interested. It's like you wipe your vagina with a swab and you wipe it around the baby's mouth to kind of stimulate their immune system. You want your partner present at all times. You might not get all these things because some providers don't like do the delayed cord clamping routinely, and they aren't comfortable with that. And during surgery, and like you know, that's understandable. Hopefully they do find a way to learn how to do that and be comfortable with that in the future, because that is better for babies and mothers. But we can't like always get the provider that does all the things that we want in surgery, and it's a little harder to advocate for all of those preferences in that space. So I just kind of want to like offer that. I think it's good to still like advocate for as many of those things as you want. If they really want baby to go to the warmer, to just sometimes they'll put baby in the warmer and make sure baby's doing okay. First, like you could have dad go with baby and say like baby will be with dad. And like once baby's out and they're stable, there's no reason for baby to not be, or your wife or partner, you know, whoever, there's no reason for baby to not be with your partner or with your mother, like anyone, to hold baby skin to skin. It's better for baby to be skin to skin than not, even if it's not with you. So if for some reason you can't hold baby, or they're like really not okay with you holding your baby, someone else can hold your baby. If you do have a cesarean, if it ends up being planned, it's great if you can have two support people. They might not let two there, but another one could come in. If someone goes with baby, another person can come in and be with you. So, okay, newborn procedures. Oh, yeah. So I did put skin to skin there. So skin to skin immediately, vitals taken on my chest. So after the baby comes out, we want baby to be with you immediately. If someone wants to listen to baby's heart rate, and check their temperature and things like that. They can do that with the baby on you. Your feeding plan, you could put exclusive breastfeeding if you're planning to do that. You could say formula, whatever. And then I accept or decline a newborn bath. Newborn bath is actually considered by evidence-based births to be a procedure because it can be painful for babies, and we have research to show this. It's ideal to wait 24 hours at least before doing your baby's bath because they're born with all these microbes right on their body that is really beneficial to stimulate their gut and to stimulate their immune system. So we want that stuff to stay on them. I waited days before bathing my baby. You don't have to wash your baby until they actually get dirty. If you get all sweaty, if your breast milk comes in on day like 3 and they get like breast milk, right, like under their neck and their armpits and they smell bad, like wash your baby, but you don't have to bathe your baby immediately. If you're in the hospital though for over 24 hours, they can wash your baby for you if you want. There are ways, evidence-based ways to reduce pain for babies during procedures, including a bath. And some of those are nursing on you, right? So we could do kind of like a little sponge bath while they're nursing. You could have your hand touching them. You can be singing to them, like if you're with them. That's been shown to reduce pain for babies during procedures, bath and otherwise, like the other tests that they do. Let's see. I accept or decline hepatitis B vaccine. I accept or decline vitamin K. If you accept it, you can say it'll be given with baby in my arms. And then I accept or decline erythromycin. So any questions about vitamin K, hepatitis B, or erythromycin? I think hepatitis B might have been removed actually from the CDC schedule recently. Yes, vitamin K in mouth versus needle. So I have, how about I share this video and then I will share some resources with it and I'm going to post it into the community. And so you're welcome to like check that out and I'll have those resources there. I highly recommend you listen to Evidence-Based Births Vitamin K podcast and it covers this. And yes, I'll add the flashcards too. Totally. I'm going to write this down because I will forget. Flashcards and vitamin K. Okay, I'll make a post in school, probably tonight because I have to go get my kids here soon. So the difference between the drops and the injection is that we found through research in Europe that the drops are effective at protecting against vitamin K deficiency bleeding, which is what we're concerned about. The thing about the drops, though, is that you have to give them on a specific regimen. You have to do it multiple times. If the baby spits up, it needs to be taken with the feed because it's a fat soluble vitamin. If the baby spits up, they could spit up some of that and then you're not quite sure how much they get. So that's just something to be aware of. And 2 other things. One is that there is not a third-party tested vitamin K drop for newborns in the US. So you have to order probably from another country. There's vitamin K drops you can buy online, but we don't know for sure 100% if what they say is in there is exactly the amount because they're not third-party tested. And the other thing is that if your baby does happen to have, so unlikely, but if they have a undiagnosed gallbladder issue, that could potentially lead to them not being able to process the vitamin K through the drops, which makes them susceptible to vitamin K deficiency bleeding. And that's why they do the injection, because for all babies, even if the baby, doesn't have, or if the baby like happens to have a gallbladder issue, we're giving them this injection, which is making sure that they get the vitamin K. The risk for vitamin K deficiency bleeding is 1 in 10,000. So it's so rare and so unlikely. And yes, doctors do require it for circumcision. Yeah, to my understanding, like maybe there's a doctor out there that does it, and I'm sure that's like possible, and you can totally look into that. But so far in my career, what I found is that yes, doctors do require the vitamin K. You can ask them if they're okay with the drops. And maybe some doctors would be okay with the drops instead of the shot. Yeah, there are some myths out there about the shot. Like it has toxins. I just saw this like Instagram video. I wanted to like respond to it. Maybe I will one day. And the guy was like, vitamin K has like formaldehyde and like all this aluminum. It doesn't. It doesn't. It's not a vaccine. Some vaccines have those ingredients in them for a reason. And it's like that's a whole nother topic. And obviously it's not ideal, right? At all. But vitamin K doesn't. It has a salt and a sugar to stabilize. It has a preservative but you can get a preservative-free option. Yeah. Okay. Bye, ladies.
You have a great day.
Thank you. Bye.